Uh, Fantastic talk. So, thank you, Dr. Rishi, for covering some important parts of this. So, I can directly skip to the donor preparation. So, an ideal donor should be whenever you're starting first few cases. It's better if we choose a donor tissue with a donor age of around 50 to 65 years, because the lesser the age, the tissue tends to be it scrolls tighter, and it is very difficult to strip in the initial days when you start your first few cases. And I would it's good to have slightly smaller size scrolls rather than doing larger scrolls more than 8.25 or 8.5 mm. 8 mm is very good. You can also try 7.75 to begin with at a safer side. And better take tissues stored in MK media, because they are easier to scroll, easier to strip compared to the cortisol. And always check, if preferably if the donor is phakic, that's much better. The tissue tends to be less fragile. And if it is pseudophakic, if you have no other option, always examine the sides wherever there is an incision entry for side port or main port, and avoid including that in your trifine. So this is already covered by Dr. Rishi, and I will be talking about there are many techniques in donor preparation. But to begin with, in your earlier days, a simplest technique is double punch technique. And I'll just take you through some videos. One video I will just show you overall what all the steps involved, and then we can focus on each and every step as quickly as we can. So in first and foremost, it's important to center the graft, as we just marked it with the marking pen, so that you can take a suction trifine and center it properly with that mark to the center of the trifine. Then going ahead, it's if you have a suction trifine, very good, you can apply suction at this point of time. Even if you don't have a suction trifine, you can go ahead with a madhu trifine. But the trick here is delivering the right amount of pressure when you give the taps. So if you have a coronet trifine, which are difficult to get by now at this point of time, this is a very good trifine. So what I do usually is, you can just rest it on the endothelium and just tap it, maybe from the the terminal phalanx, and tap it all 360 degrees round and round, and then keep rotating your anterior chamber so that you cover it 360-degree. Gentle taps. But when you're in your earlier days, I would recommend the taps to be little firmer, because it is always problematic if the descemet doesn't cut through. Then you stain with trypan blue and check how is the cut. So here you can see your cut. Here I've deliberately taken this video to show that it was slightly eccentric, and that is because the scleral rim in this video was large. So when I put the guard, the graft has gone little bit to the other side. So even in these cases, how the double punch technique is useful, I'll show that. So now you can see that trypan blue has actually marked the size where it has cut through. So using a normal Sinskey hook, I'm just trying to see if it has raised the peripheral frill. Now this is the area where I'm not seeing the staining, so naturally this has gone to the periphery where there are thicker adhesions. So I'm just trying to see if any area is loose over here, and if not, you can actually score it again with the same Sinskey hook in that area and try to raise that peripheral frill. Now comes removing this peripheral descemet beyond the margin of your strip cut. So this is very useful, because when you remove this peripheral descemet, the actual peripheral edge of your scroll starts freely floating within the fluid, and that is what you want. You want the graft centrally attached, and then the peripheral frill to float in the fluid, so that it gives you that grip to hold with a, this is a curved tying forceps, titanium tying forceps, and to hold it at one edge and then start stripping. So if while stripping, it is important to maintain and see a straight line here. This is slightly out of focus, I'll show it in the next video. And once you strip it, keep the central area well attached. Do not strip it beyond that area. So you can do it at three main regions, and keep the central attached. Now comes the second punch. So this is the area where, if you have gone wrong in the initial step, if there are any tears and tags, you can exclude that area and fit in the healthier region within this 8 mm graft and tap again. Gentle taps, and strain it again, so that excess rim between the 9.5 and the 8 refine usually comes off very easily. So scroll preparation and overall DMEK is all a game of fluids, and here is where you should apply no touch technique, where you should use the Vexel sponge wisely to move your graft fold or unfold onto itself without touching it too much. So now I have done a 50-50 fold, where I have folded it onto itself, so as a bare stroma is exposed, and using the 3 mm Trifine as shown by Dr. Rishi, we punch a hole, so that this stromal cap will help us in marking the tissue. Now there are various new methods like the BCL technique and all, where you can prevent this particular step and save the tissue for any other stromal lamellar transplants. But this is for in the beginning stages. It's very safe to get a very good mark, because a mark is very important in the initial learning stages. Again, if you see there is excess of fluid, the graft will tend to keep floating. So in this case, it is very important that you use the Vexel sponge, push the tissue or tilt the anterior chamber in a way that the fluid is drained downwards with gravity, and drain it with the Vexel sponge. With the fluid current, the graft will fall back. Again, this window which is cut through, it has to be fully dried with the help of Vexel sponge. Reason beyond, we don't want the mark to smudge. And tip here, the fluid will tend to seep again and again through the peripheral edges. So keep drying it with a new Vexel sponge tip until you see that pitted appearance in the base of the the duas layer on top. So you can mark any asymmetric letter of your choice, but make sure it does not smudge. That's the most important thing, because you want it to remain its morphology until it is inside the anterior chamber and the graft is unfolded, which will be covered by Dr. Siddhartha. So once this is done, please dry the undersurface of the cap as well, and then place it back, otherwise this smudges very badly. And once this is done, you can go ahead with staining the graft. Now this, you can do a trypan blue stain for 3 minutes or so. You can also use brilliant blue, that is, you can actually use it only for 1 to 2 minutes. It's a stronger stain. And some say that if you, there is some form of cross-linking that happens, but there are elastin fibers, so probably the light source is also working in any way. I don't know, these are all as hypothesis. But once separated, you can free float the scroll into the bath, and then take it within your syringe to float. So I think we covered most of it. I'll thank Dr. Praveen to giving some of these videos. I just wanted to show some complex situations. So this is how you should strip the peripheral skirt, so that it becomes very easy to actually lift the graft at the edge. So I'll just forward and I'll show you. Yeah, so this is the free floating skirt. This is exactly what you want when you start holding the peripheral frill with your forceps. And strip it 1 clock hour at a time. Do not rush. Do not, the pull has to be, initially it can be tangential, and then pull it towards the center slightly, because this is just frill elevation, this is not stripping. And if you feel there are any adhesions, go slowly and try to peel it until it is fully separate. If you are not able to go around it, just go from the other side, so that you are not, you can avoid a tear in those cases. So if at all there is a tear, you can anticipate these areas wherever the trypan blue doesn't stain well, or if the graft's age is more than 65, or if it is pseudophakic. and if it is very brittle, you will feel it. I mean, as soon as you hold, it will start cracking. So change the site from where you are trying to attempt to strip, and try to get an area where you're getting a free edge that is strong enough to hold and strip clearly. Okay, thank you. I think that's time up, and I'll stop here. Thank you.
Thank you, Vineet. Those were some really nice videos, and I think you put the point across very well. Um, what would you do if during the process of trying to harvest your graft you end up damaging say about 30-40% of it? Would you still proceed to try and complete it as a DMEK, or I think you guys don't have that problem because you have an eye bank and you always have backup tissue, but for a person who doesn't have, what would you suggest?
If it is a radial tear, and if your initial trifine is around 10 mm, and if there is a possibility you can decenter it and get away with a 7.5, 7.75, very good. But usually such maneuvers, I mean, what I have seen, you actually end up manipulating too much, and that actually because it doesn't go pretty well, but still you can manage. There is a good side hope is that when you're decentering it, you're actually taking a side with more endothelial cell count. So there are plus and minuses to the both. But if it is a radial tear, why, you can always circle it out like a rexis. While doing that, if you feel that the remaining tissue is good enough, large enough to form a scroll, then it's okay. Otherwise you might have to abandon.
One more hypothetical situation. In fact, faced that situation several times. When you're trying to strip and right at the periphery, it starts just tearing. It's very fragile. Now you have not come very central. You're still peripheral. You still have the chance to do a DSEC instead of a DMEK.
Yes.
So do you think it's a good idea to, if
Oh
you
yes,
start seeing that kind of a situation, to
definitely you can do. And in fact, even if that small descendants detachment stays, the DSEC graft will survive. It will
yes.
not fail, or it will not matter.
What if you've partially stripped it and then you decide to do a DSEC? Uh,
I don't
maybe.
know. Might work. I don't know.
Please come to the mic and share your experience.
So if you have like a radial tear, what you do is that you get the graft and you put it into artificial anterior chamber, and then you get your DMEK tissue, whatever the way you want, manual or with a microkeratome. But the issue is that you keep the torn part of the DMEK tissue in the upper part of the anterior chamber, so that it's supported with the air bubble, especially if it's expansile gas, for a very long time. And this will have like a scaffold where the tissue attaches very easily to the rest of the stroma.
I think that's a great idea. So please introduce yourself for the audience to know who you are.
My name is Hazem Yassin. I'm a professor in Cairo University, Egypt.
Thank you.
You're welcome.
Thank you, sir. Thank you so much.
And a student of Dr. Rajesh Fogla.
All of us are his students. Dr. Fogla has something to share.
You can always, if you have a radial tear and you feel that that segment of the DM you're going to abandon or you're going to tear it off, then instead of punching a 8, you can punch 8.5 or 9, so that you have a much larger, so the amount of transplanted endothelial cells, the volume increases. Yes. So you can always, if your anterior chamber volume allows, punch a larger graft size, so that even a loss of a 20% of tissue is compensated yes. by the larger diameter of it.
Fantastic. Yes.
Yes.
Another adding for those patients which you get the graft while they are pseudophakic. So sometimes the tunnel of the corneal incision is big and it might interfere with the separation of the DMEK tissue. So what you do is that you inspect the cornea from the beginning, and then you leave that part where the corneal incision is there and keep it as if it is the hinge where you cut through, and you don't have to go through the wound, otherwise you will induce the radial tears many times.
I think that's a very good idea, and perhaps when our eye banks are sending us these tissues also, they could try and figure out the wound area and mark it. You can just see it, yeah. Cuts.
cuts.
Right.
You can see
So I
that.
think that's a very, very good tip, and we could be
Yes.
mindful of that as well.
Yes. Thank you. Thank you.
Thank you.